All right, so last time we did kind of a number of epithelioid lesions, ranging from some vascular lesions to some kind of fibroblastic, myofibroblastic, myoepithelial. One of the ones we ended on, if you remember, was this myoepithelial tumor of bone, malignant myoepithelioma, that was one of the first ones we saw that had these very plump cells with eosinophilic cytoplasm, but this very characteristic myxoid background. And so I wanted to sort of shift the thought process now to tumors that either had myxoid or perhaps chondroid background, and see if we can sort of continue that exploration of these cases. So again, I didn't give you any clinical information. We're going to do this in a Kraussian style and see if we can sort of figure it out. But we can talk about it as we go. So this is the first case of today. And if you have or have not had a chance to preview, that's okay. But I can zoom around, and if someone at least wants to describe to me what they see, that would be great.
It also has a very myxoid looking background, with the same kind of floating cells that you see in myoap. I don't know if the cells look exactly the same, but it's definitely reminiscent of that.
And what might these cells have that those other cells didn't have quite as much of?
A ton of this like pink cytoplasm.
There's a lot of pink cytoplasm, and within the pink, there's also these
like
vacuoles.
Yeah, like vacuoles. And I know that they're not everywhere, and I know that I just pointed you to a blurry one, but as we scroll around, exactly, you could sort of see these vacuoles within the abundant pink cytoplasm, all of which of these cells, again, are embedded in this myxoid background. So what would that make you think of? Oh, there's a mitotic figure.
Myxoid liposarcoma.
Okay, so if you want to think about myxoid liposarcoma and you think that these vacuoles are fat vacuoles that might make up a lipoblast, do these fit for the morphology of liploblasts?
You want like an indented nucleus that's being kind of, squashed by the fat vacuoles, or like even more like triangular pyramidal sort of nuclear shape.
Exactly. Yeah. So the key with liploblasts is that, if this is the fat vacuole, as Perry said, it indents the nucleus, right? So if you have a univaculated lipoblast, the nucleus is out here. If you have a sort of a double vacuolated lipoblasts, the nucleus is kind of triangular out here. If you have a multi-vacuolated lipoblast, then the nucleus can take on all kinds of weird shapes. But the point being that exactly it's squashed. And so in these cases, the nucleus does not appear squashed at all, right? It's nice and plump, and it pushes the vacuole aside rather than it being pushed aside by the vacuole, right? So that helps in saying that these are not lipoblasts. All right, so what else might we think about?
I don't know if we're still thinking like myoepithelial origin, but the vacuoles, I don't know that.
Okay.
Go ahead.
Oh, I think someone else was trying to say something.
Yep.
Yeah. Pseudolipoblast in myxofibrosarcoma.
Okay, pseudolipoblast in myxofibrosarcoma. So that would require us to potentially see some prominent curvilinear blood vessels, which at least on casual glance, I don't really see. The other thing about myxofibrosarc is that Arguably, these cells have a little more cytoplasm than we would want for myxofibrosarc. And do they have a significant amount of cytologic atypia that we generally tend to see in myxofibrosarc? Or are they more bland?
If it's low grade, then it will be more bland.
Yeah, so low-grade myxofibrosarc is less cellular than the higher grade ones, but arguably it still retains some of the cytologic atypia. I mean, here's one larger cell, but what we don't see are those very large hyperchromatic nuclei that have sort of angulated borders. We saw one mitosis, but we don't see a lot, which again, in low grade, you might not expect a ton, but to me, the more striking thing here that would really push me aside from that would be the, excuse me, again, the cytoplasm. There's quite a ton of almost glassy cytoplasm in these cells. There's not much kind of pleomorphism, and there is this cytoplasmic vacuolization, and there are not prominent curvilinear blood vessels. One here and there, but not a lot.
Would you call these vacuoles bubbly at all?
Well,
Yeah.
they look bubbly
Ryan.
to you. All right. So I think
Like-
we're getting somewhere. And
Chondroma.
Like
yes,
can you
yes.
have like a chondroid card or like a
Yeah. Chondrosarcoma also myxoid type.
So I think we talked about myxoid chondrosarc and how we don't really think that these are lipoblast. I'm thinking liposarc. Myxoid variant of chondrosarc. Okay, yeah. So if you have chordoma on your differential, depending on where you are, myxoid variant of chondrosarcoma, yes, can also come into the differential. Myoepithelial tumor can absolutely come into the differential because, as you saw, the morphology, the arrangement of these cells is extremely similar within this myxoid background. But the glassy cytoplasm and the bubbly vacuoles almost sort of give this away. And I didn't want to tell you the location of this because as soon as I did, you'd know it, right? Like it's at the base of skull, or it's at the sacrococcygeal area. Like once you have that clinical information, you jump to a diagnosis. And I think really having to investigate these tumors without knowledge of where they are, it can be very helpful because they can look like so many other things. And so, when you have this type of morphology, what immunos are going to help differentiate this from the other things we've talked about? So from a myoepithelial tumor and from a myxoid chondrosarc, or even from a myxoid liposarc, from a myxofibrosarc, tell me what do you want to order? What do you want to do?
S100.
Pardon?
S100.
S100, and what do you expect in chordoma?
Chordoma, I think it is I don't remember. I just remember brachyury will be positive.
Okay, so the brachyury is definitely the most specific immunomarker, which is nuclear distinction, which is of notochordal origin. We unfortunately don't have brachyury because we don't have that many chordomas, but in institutions that are chordoma centers, they tend to have brachyury. So ours would be a send out to Mayo, but yes, definitely you can do brachyury. But while you're waiting for your brachyury, so you asked for S100. Does anybody know if S100 is positive in chordomas?
I think it's positive in chordomas, right? Because it's all like neural crest origin.
Correct. So S100 is positive in chordoma. Brachyury is certainly positive in chordoma. What's the last one that we expect to be positive, or last couple?
Like EMA.
Mm-hmm. Exactly. So if you have an S100 and an EMA positive tumor, but you're waiting on your brachyury, what else is S100 and EMA positive that we just saw? Or could be a myoepithelial tumor.
Yes.
Exactly. And so historically, I'm just going to write this down here for a second, S100/other, but historically, there are these tumors in the literature called parachordomas that were thought to be chordomas primarily arising in the soft tissue. So in like the paraaxial space, right? So, trunk, extremities, whatever. that were S100 positive and EMA positive. Well, guess what? These all retrospectively, most of them were shown to be brachyury negative and are actually, soft tissue myoepitheliomas. So this differential diagnosis is important and interesting, I think, because of this historic confusion between myoepitheliomas of soft tissue and primary chordomas of soft tissue. Primary chordomas of soft tissue do not exist. So if you see something that's in the soft tissue, not the base of skull or sacrum, it's either some kind of direct extension from a local chordoma, or it's a metastasis to the soft tissue of a chordoma. We know that chordomas are regarded essentially as having metastatic potential. And we've seen these metastasize to things like, lungs, whatever, even in a morphology that is, not really high grade, right? So they can metastasize in a sort of low to moderate histologic grade appearance. Does that all make sense? All right. And so then if we were thinking, go ahead.
Oh, I was going to say, I have a completely just academic only question.
Yeah.
We're talking about it not being like lipoblast, not being lipid. I mean, what is within these? Do we know what the material is, or speculation?
That's an excellent question.
Like, is it PAS positive? Has anyone ever even?
I do not know. That's a really good question. If I find it, I'll let you guys know. If you find it, let us know.
Sounds good.
It sounds like a plan. It may or may not be fat, but I guess the point is that in most cases, the vacuoles don't indent the nucleus, which is why it's not a lipoblast, right?
Right.
So
Yeah,
whether
it's
or
not
not
because of the material, it's
exactly. But we'll find out. I don't know if it is fat. It certainly doesn't have a tendency to indent the nucleus. Hence, it's not a lipoblast. Yeah. All right. And then lastly, if we were to think about our myxoid liposarc or our myxofibrosarc. So why can't I get back to this? Myxofibrosarc would essentially have nothing. Like, it would stain for nothing, except for maybe some SMA if it's a myofibroblastic differentiation. Myxoid liposarc, what's going to be your diagnostic test? Here we go.
Fish.
Right. Fish, exactly.
Implication.
DD.
Exactly.
IT3.
Exactly. So this generally doesn't also have any specific immunomarkers per se, but rearrangement. Excellent. Great. What the only other tumor that I can tell you that has any specific genetics is sometimes the myoepithelial tumors of soft tissue. What do those sometimes have? I think we talked about this last time. Do you remember?
EWSR.
Yep, exactly. So these about half of them, especially if they're malignant, can have EWSR rearrangements. So great. Okay. So S100 EMA, brachyury for chordoma, keratin. So great. Clear all drawings. Remember that chordomas can, what's the bad thing that chordomas can do? Other than clinically metastasize, histologically, what can they do?
Become poorly differentiated.
Yeah, they can become poorly differentiated and so-called de-differentiate, in which case they have a sharp transition to a high-grade undifferentiated spindle cell neoplasm. So just like chondrosarcs can de-differentiate, chordomas can de-differentiate into a spindle cell type of process. Oh, the one thing I forgot to put on that list that I just deleted was the myxoid chondrosarc. And if you're lucky, we may or may not get to a chondrosarc today. But again, that would be negative for keratin EMA brachyury. But what is a marker of chondroid differentiation that it might have?
SOX9.
SOX9, yeah. So that could be helpful. Okay, great. Any other questions? So that was a chordoma. Oh, the other thing I will mention is chordomas generally have this myxoid background, but they can, in some circumstances, have true cartilage, true chondroid. So those would be the chondroid variant of chordomas. There was some debate in literature about whether there was any prognostic differences to that, and it's essentially been shown that there are not. So the only prognostic indicator in chordoma is dedifferentiation. Okay, next. You're going to tell me, God, Nicole, all these look the same. Yep. This one arguably does not have such vacuolated cytoplasm or such abundant glassy cytoplasm as the chordoma. I'll tell you, this is located in the deep soft tissue of the extremities of an adult person. It's not associated with bone. Does anybody want to throw on another entity other than the ones we've already talked about?
Acrofibromyxoma?
So like a cellular myxoma?
Fibromyxoma. As you said, extremity, I just thought acrofibromyxoma.
Oh, acrofibromyxoma. Yeah. So if it's not in a distal site like finger, palm, nail,
Yeah.
in the skin, yeah, you're probably not going to be dealing with superficial acrofibromyxoma. But yeah, if you were in the correct anatomic location, certainly. But this is deep and this is not distal. This is deep and proximal. So we're kind of have to shift our viewpoint a little bit. And it's quite large. I mean, I guess if you think about superficial acrofibromyxomas, they tend to be kind of small-ish. This is a nice core of what appears to be a perhaps larger lesion, but yeah, that's definitely a consideration in the right context.
Could we think like, I don't know, like extraskeletal, what is it, like mesenchymal or myxoid chondrosarc?
All right, so tell us what you know about that.
Very little. It has like this sort of mesenchymal look. It's, you know, these sort of spindly cells embedded in a very, very myxoid background. I think these tend to be sort of in the deep soft tissue of adults. I always get them confused. There's like the mesenchymal one, which is like for the head and neck, like younger men, I think. So I don't think that's it. But the myxoid one, I guess, has like that characteristic NR4. I always think of like the NRA. I think of like
I think of that.
yeah, like a gun-toting guy with a pistol in his back pocket. So that's how I remember, like it's sort of deep and proximal.
That's
NR4A. Yeah, that's it. Yes, that one.
Did I get it right? NR4A3?
I think so. Yeah.
Okay.
Something like that. And then like, what is it? EWSR is the partner or something to that.
Yeah.
I think.
So with some variability, but yes. So, all right, great. So I'll just tell you that's what this is. So this is an extraskeletal myxoid chondrosarcoma, and it fits very appropriately in this differential diagnosis of soft tissue lesions that have myxoid stroma and essentially relatively bland cells that have, you know, scant cytoplasm, almost wispy cytoplasm in areas, but really not glassy, not foamy, not super mitotically active. And the two key things that you might think about morphologically, besides extraskeletal myxoid chondrosarc, to me, these look nearly identical to, again, myoepitheliomas. All right. So to me, the main differential diagnosis here is a myoepithelial tumor versus a chondrosarc. Mesenchymal chondrosarc is yes, most commonly found in the head and neck, in the jaws, but is blue. It's blue. If you think about like primitive mesenchyme, it is like blue and highly cellular and spindled and has sort of, you know, abrupt areas of cartilage. So even though the words sound the same, you know, mesenchymal chondrosarc, myxoid chondrosarc, the morphology is drastically different. So mesenchymal, really think about primitive mesenchyme and very blue. Myxoid, think about a myoepithelial tumor. So if you, in this case, if you do your, what stains again are we going to do for myoepithelium, right? We're going to do some kind of EMA or keratin, some kind of S100, GFAP, P63, P40, SMA, right? You've thrown the book at this case and you don't have any significant staining, then you do the FISH, right? So there's no specific immunomarker for this tumor. It's a diagnosis of exclusion, which you have to basically confirm with FISH because these are quite rare. And so I would definitely do the molecular confirmation. Sometimes people regard these as almost the wispy cytoplasm of the cells are kind of like holding hands, like they're outstretched in like a, I don't know, like a little linear fashion. And so these little tumor cells are kind of holding each other's hand in this little ring of fire. I don't know. So I thought that was an interesting morphologic area there. Comments, questions?
Last time I read about this, I
Mhm.
read that they had interconnecting cells. Is that what you meant by the ring of fire? Or
Yeah,
do we just not appreciate that
yeah.
here?
Yes. Yes. So interconnecting is probably a better word, but somebody once described them to me as holding hands, which I think I like. But yeah, like they send these little bridges out to each other. Like there. And this is a nice area, but it's kind of behind the blur, right? There's one. There's a nucleus that's connecting to another right there. Yeah. Almost chicken wiry, exactly, but it's not vessels, it's cells. Cool. What else? All right, so we've touched on the three things that appear super morphologically similar: myoepithelial, chordoma, extraskeletal myxoid chondrosarc. All right, so now let's move on to this one. Oh, goody. More cells floating in a myxoid background. Are these cells touching or connecting?
No.
No, they're not even clustered. They're like so spaced out in their individual little areas. Ooh, what's going on here?
Do we have some tumor necrosis?
Yes, so these pink goobers are basically dead nuclei, exactly. So I'm always careful in lesions with myxoid background or chondroid background to identify necrosis because it can be subtle. So you're basically looking for a slightly darker pink on top of a slightly paler pink, right? And so here's the viable nuclei. And over here is an area where the nuclei are gone. And so these two, of course, are viable, but these pink areas are where the cells, where the nuclei used to be. So yes, absolutely, you're dealing with necrosis. And so necrosis in here's more, any primarily biopsied neoplasm that has never been touched by a human before, right, is worrisome. All right, so we've got necrosis and we've got a somewhat cellular area. Also pretty bland, also pretty isolated cells. So what else do you want to think about that we can add to our differential here?
It looks so chondroid.
Yes. Now we've sort of morphologically shifted to a vaguely more chondroid appearance. So the background has become a little bit more arguably homogeneous and dense and almost like glassy, like hyaluronic acid. So thinking more about cartilage rather than just myxoid, although there's certainly a spectrum. What else makes you think about cartilage or chondroid?
There are some binucleate cells also.
Yeah, there are binucleate cells. Yeah.
Yeah, they're living in their little lacunae. Um,
Yeah,
Exactly.
very small and dark too, as opposed to like the other ones that we've seen.
Exactly.
That looks more, reminds me more of Chondroid than the other entities.
Right. Yeah, no, exactly. So they are all in their individual spaces or their individual lacunae. The lacunae certainly have nuclei, but of course there's also this kind of a rim of pale-ish cytoplasm, right? So pale-ish cytoplasm and nuclei present in individual lacunae, some with binucleation, no apparent architectural connection, attachment, grouping, clustering, not really, right? So that's indicative again of those lacunae and that glassy background and very small dark round nuclei again, exactly. However, small dark round nuclei, but interspersed with some individual necrotic chondrocytes. So this is a tumor that's involving both the bone and soft tissue of the humerus and sort of perihumeral area. So any thoughts on what this might be?
Is it possible it's like a periosteosarcoma, or is it peri, or like one of the more chondroidy?
yeah, is it the peri? Well, yeah. And is it the periosteal osteosarc that's like actually more
Yes.
ophthalmic?
All right, so periosteal osteosarcoma, you
Or I guess-
expect, is that,
Well, I mean, or just could it be a straight up, chondrosarc?
Yeah, that's also,
okay,
yeah.
yep. So okay, let's start there. So for the periosteal lesions, whether they be osteosarcs or chondrosarcs, you want to see sort of a attachment to the outer surface of the periosteum with, let me see if I can draw here. All right, so if this is the bone, these are sort of primarily based out here, and sometimes have, generally minimal extension into the underlying cortical bone, but should be sort of centered on the periosteum. Periosteal osteosarcs tend to be present in sort of a younger age group, just like how we would see conventional osteosarcs, and tend to be more on the surfaces of the femur rather than the humerus, but that these are all just generalizations. Periosteal chondrosarc certainly has a similar kind of centered appearance on the periosteum with bony infiltration. So in order to differentiate periosteal chondrosarc from, if you are in, on, or around a bone, what is our other cartilaginous sarcoma that it could be? How about just a conventional intramedullary chondrosarc that may or may not have bony extension, right? So in this case, you're dealing with something that perhaps originates in the bone and then has outward extension into the soft tissue. All right, so where the tumor is centered and how it's getting there is very much of a discussion you should have with the radiologist, right? Because when you look at just this, it's very challenging. And yes, extraskeletal myxoid chondrosarcoma that is arising in the soft tissue. And again, so maybe here, let's draw it out here. Say it's out here, right? And it's eroding into bone. Absolutely, that's definitely another option, right? So we have a lot of options that this could be. Many of which are going to be dictated both by morphology, immunostains, as well as imaging. All right. So this is an older male who has involvement, like we said, of the humerus with both soft tissue and bony involvement. And so, in this case, it can be hard to tell whether it's outgoing in or, in going out. And so in an old man, in a proximal osseous site, this is going to be less likely. generally, this is also going to be a little bit more cytologically atypical. So we're not in the right age, we're not in the right site. We slightly don't have the right morphology for periosteal osteosarc. But certainly a periosteal chondrosarc or a conventional intramedullary chondrosarc are the options. And this is really only distinguished by imaging. Both are cartilaginous sarcomas. It's sort of a matter of, does it primarily start right like this or start in the bone and go out? And so is there anything by immunos or molecular that's going to help you with a conventional chondrosarc?
I think IDH1 mutation.
Yep. So the only thing that will dictate to you that this might be of cartilaginous differentiation is going to be a SOX9. And the only mutation that is going to tell you that it is a cartilaginous neoplasm is IDH1. Exactly. The problem with IDH1, which is why we don't generally use it, is because it's mutated in both benign enchondromas and chondrosarcomas. And so it's not going to tell you benign versus malignant. It'll just tell you that it's a cartilaginous tumor. If there is some kind of indication that this is, like we said before, a manifestation of a chondroblastic osteosarc or some other tumor with chondroblastic differentiation that is not primarily cartilaginous, right? So IDH1 and 2 are only found in the primarily cartilaginous tumors, not the tumors with cartilaginous differentiation, okay? Molecular was not done on this case because it was felt that all of the other immunomarkers were negative. SOX9 was positive, and the radiographic features of a lesion in the proximal humerus of an old man with osseous and soft tissue involvement was most clinically and histologically consistent with the conventional chondrosarc. So pretty much once we sort of know where we are and we know we're dealing with cartilage, any cartilaginous neoplasm in the proximal sites of an older person is nearly by default chondrosarc until proven otherwise. And so if you are in a younger person, if you are in a distal space, you could think about an enchondroma of bone. But once you are in an older person in a almost a girdle, right? Like a limb girdle, scapula, humerus, pelvis, proximal femur, you're basically at chondrosarc, regardless of whether you see necrosis type of stuff or not. So generally we sign these out as low-grade cartilaginous neoplasm, favor chondrosarc or favor enchondroma or whatever, depending on the clinical circumstances, because if you showed me just this one field, like it's very hard to say that this is malignant. But once you put the imaging and the necrosis along with it, then you're really at a chondrosarc. And so as long as it's low grade, lower intermediate grade, they generally primarily resect these because they do not really respond to any kind of chemotherapy. So primary treatment for these low to intermediate grade is surgical. Comments or questions? Was that helpful?
Yes, thank you.
Yeah.
Sure. I think seeing all of these that have basically the same differential diagnosis in context can be very helpful to sort out the subtle morphologic details. And if I haven't given it to you already, I will send you the link to this presentation. So the next one is not so diagnostically challenging, but I thought it was important to put on here. You can basically look at this and just tell me what it is already. Fragments.
Osteochondroma.
Yeah.
Osteochondroma.
It's a osteochondroma.
Great. So bony core, right? Cartilaginous cap. I always want to remind everyone that Osteochondromas are primary cartilaginous neoplasms, right, of bone. They are not bony neoplasms. The bone is just induced by the cartilaginous cap. If you ever have to gross one of these, please always try to section the lesion perpendicular to the cartilaginous cap if possible, because we want to get the measurement of this cap thickness because the surgeons and the clinical teams are interested in that. Why? Because once the cartilaginous cap starts to overgrow a cauliflower-like fashion, then that's chondrosarcoma, right? Secondary chondrosarcoma arising in an osteochondroma. That tends to happen in patients with, multiple hereditary exostosis or multiple hereditary osteochondroma. And so the measurement of that cap gives them some indicator of, their, comfort in calling this benign. If any of you, I don't unfortunately have a scan of it. It was just a recent case from the other day, but there is a case going around now in the department of a secondary chondrosarc arising from an osteochondroma. And the point is that no longer do you retain this nice, beautiful cartilaginous cap, which you will, of course, measure for me, both for me, for the patient. You will measure both grossly and histologically, make sure that it correlates. But thanks, Heather. Once James has the slides. Awesome. Yeah, I would love to have one scanned we could throw it in this presentation. Once you start to have a cauliflower-like growth out here, yeah, that's no longer benign, regardless of how bland or paucicellular, the morphology of these cells is. So always, generally it ain't going to come to you without a clinical suspicion of secondary chondrosarcoma, because they radiographically, monitor these patients. These things start to grow, and they're never going to resect, at least in this institution, they're never going to resect it without some indication that it's grown or big or worrisome for chondrosarc. So you should know clinically that that's a concern. Comments, questions? Okay. Next case. This one's a little bit different, so I'm going to let you guys look and then someone can describe.
Yeah, I'll give it a whirl.
Thanks.
So I guess compared to the other ones, the background is a little more purple. So maybe, I guess like it's still myxoid appearing, but maybe a little more cartilaginous. I don't know. I guess like it's kind of hard to tell for me personally as to like what between the two. And then we have this like areas where it is more hypercellular and the cells are more round, and then these areas where the cells are not, I guess like a little smaller and more like myxo, I guess like for some reason it reminds me of like a myxofibroma, but I don't think, we just talked about these things, so it's not exactly what it is.
All right. Yes, and I haven't told you where this is, so
No.
my bad. So, do you want to know where it is, or should I have you struggle? No, just kidding. This is now a bony lesion. All right.
Okay.
So does that help?
I guess somewhat. Yes.
This is no longer a soft tissue lesion. This is an osseous lesion in a young person.
Okay, so does help a little bit.
Would you classify this as like a small round blue cell tumor?
Yeah, because there are some areas that are small round blue celly, but I don't know if that's like the
like the predominant feature.
Yeah, the predominant feature, maybe it's like starting to de-differentiate to like a small round blue cell at the edges or something.
Yeah, so I'm gonna say if these are the areas you're looking at that you're thinking about for small round blue cell tumor, I would agree that these areas are, while they are more cellular, they are not the predominant morphologic pattern here. And one could argue that I'm not even sure they're entirely round. So
They're small and bluish, but
they're
maybe
small and blue, but kind of pointed and kind of separated by some stroma still, right? Still.
Mm.
Even though they're relatively more cellular than the other areas, they are still separated by some stroma, and they don't have that. You know, when you say small round blue cell tumor, you imply malignant. And I haven't seen tons of mitoses or apoptoses or necrosis here yet. So just be cautious with those words, especially when that's not the dominant pattern. So Anushmita is saying that she sees stellate cells with curvilinear blood vessels and might think about myxofibrosarc. So again, I think that morphologically, that is certainly a possibility. But if we now know the context that this is an osseous lesion of a young person, then that essentially makes that much less likely, because we would be looking for myxofibrosarcomas mostly in the deep soft tissue of an older person. All right. Ossifying fibromyxoma. All right. Have you seen bone?
Yeah, no.
Okay. There is this pink stuff in the background, but I think it's more collagenous. It's sort of globular and wispy, not wispy, like cracked, rather than fine and dense like osteoid. So I think that's collagen rather than bone. All right. Anybody else have a guess?
What about chondromyxoid fibroma?
What about it? Tell me what you know about it.
It's in young people.
Yep.
In the metaphysis,
Mm-hmm.
and it has myxoid cartilage, which this seems to have,
Mm-hmm.
with spindle cells and pink cytoplasm.
Mm-hmm. And characteristically, what also does it have? I'm trying to show you here.
A rim of these more dense cells on the periphery.
Yes, yes. So this is actually quite a characteristic feature of this tumor, which, thank you, Magna, is chondromyxoid fibroma. So, you know, the biopsies of these types of lesions in, you know, I know we're not doing a bone session, but because we were doing a cartilage session, I thought I would throw that in there. Yeah, this is a nice example. And so you may get this for frozen, because in these bony lesions in kids that they have some indication of what they are, they will already have an indication that this might be a CMF. But if you see this, you know, bland cartilaginous or myxoid type of tissue with these cells that aren't quite interdigitating, but arguably have stellate cytoplasm, and highly, I don't know, I don't want to say specific, but a great indicator of CMF are these hypercellular areas at the periphery that sometimes you can see multinucleated giant cells. I'm not sure that the giant cells in this tumor are prominent, but this zonality, and they kind of chunk out such that the hypercellular areas tend to be sort of at the periphery of these lobules. I'm not sure architecturally or biologically why that happens, but seeing these multiple lobules with hypercellular peripheral zones is really, really great for chondromyxoid fibroma. Yeah, so that's what this is. These are benign, and what they can do, I think last year I may have given an example. What they can do is they can actually have quite significant, almost degenerative or like a simplastic type of atypia that might make one worry about a malignancy. So all that was a good lesson for me in terms of how atypical these CMFs can actually be. So chondroid lesion or a chondromyxoid lesion in a young person with hypercellular areas, think about CMF and quite a significant amount of cytologic atypia is actually allowed in these, as long as there's not significantly high mitotic activity or morphologically atypical mitoses. Questions? I may have an example, if you give me 2 seconds, I may have an example of a CMF that has some pseudomalignant change. Oh yeah, this is it. All right, let me share this screen. Where did my Zoom controls go? Okay, hold on 1 second. Yeah, this is it. So, similar clinical picture of a young person with a metaphyseal bony lesion. In this case, you see some actual potentially osteoid with entrapped osteocytes, which of course always raises the possibility, is this adjacent bone, is this reactive bone, or is this lesional bone? In some areas you get this hypercellularity. You certainly get this kind of myxoid stellate shaped type of cellularity. And then in areas you get these nuclei that stand out as enlarged and hyperchromatic and kind of multilobulated, multinucleated. Here's another one, right? So these start to pop up and can certainly be worrisome for some kind of atypia in a chondrosarc, or if you saw that bone, even atypia in an osteosarc, a chondroblastic osteosarc. I mean, this is challenging. So I will tell you the final outcome on this case after consulting with multiple outside experts was a, quote unquote pseudomalignant chondromyxoid fibroma. But in time, these types of lesions have shown to behave quite indolently in these young kids. So there's a giant cell there. So yeah, this is an example of a so-called pseudomalignant chondromyxoid fibroma. So if we get, what I can do is I can put this image in the presentation, and if we get a scan of that secondary chondrosarc, I can also put that in the presentation just for you guys to have as reference. But kind of scary, huh?
Yeah.
All right. Cool. Questions, comments on that one at least? Okay. And then, oops, I went to the wrong one. Stop share. This is the one I want. All right, where are you? There. All right. Can you see slide number 16 here, the last one?
Yeah, we can.
All right. All right, so this is the last case I have. As you might imagine,
Is this
There's-
also from in the bone too?
it's also from in the bone.
Yeah.
There's now a theme. We've now transitioned our theme. Tell me what you're thinking.
Well, yeah, there's a lot of cartilaginous areas. There's like a more hypercellular, not like, I guess, roundish cells. There's also like a lacy osteoid in here too. And then some of these cells like look like very like plump and eosinophilic, but I don't think look overtly malignant or anything like that.
All right, so this is another bony lesion in a young person. with cartilage, with giant cells, with some, like you said, some fine calcification. So what are your folks' differentials? There's your calcification.
Like a
Chondroblastoma.
Yeah.
Great.
You can have
Go ahead.
these- oh yeah, that's like chicken wiry calcifications,
Mhm.
like in giant cells.
Yeah, great. So this, you know, this is a very nice example of a chondroblastoma. Sometimes you are missing one of those features, but in this case, you essentially have all of those features. It's great. So you have sheets of cells with interspersed bystander giant cells. The cells behind the giant cells, the mononuclear cells of chondroblastoma, you may remember, tend to be almost like kidney bean shaped or curved. And it's a little bit blurry. Here's a nice one here that's kind of curved, rather than plump with nucleoli. So once you start to see cells in the background that have plump nuclei with nucleoli that resemble the nuclei of the giant cells, that's the characteristic kind of buzz point for a giant cell tumor of bone. But once you start seeing cells in the background that have slightly darker nuclei with arguably some kidney bean or curved shapes, that is better for a chondroblastoma of bone. So those are subtle cytologic differences that help you between giant cell tumor and chondroblastoma. The other features that are certainly going to aid are going to be the presence of neoplastic cartilage, as well as fine calcification of that cartilage. So here's a nice area where you start to get some expansion of the stroma between these cells in kind of that glassy chondroid hyaluronic acidy type of look. And then that cartilage starts to calcify such that it surrounds, right, each of the individual lacunae of these chondroblasts, and resulting in that chicken wire appearance. So yeah, great, nice example here of a chondroblastoma, giving you all of that, the characteristic pictures. What else? Are there other, we have like 5 minutes left. Are there other tumors that you want to see that came up in your differential diagnosis, or questions that you have on the cases? Or is everybody satisfied?
I feel like all the different variants of osteosarcoma, there are so many, and I don't know, clinically how, those distinctions play out. But I know like they have their different, characteristic histologies. I wonder if at some point maybe we could go through some of those, the intramedullary versus the, what is it, periosteal versus all those different types, paraosteal versus periosteal, like all of those, I just sort of makes my head spin.
Yeah.
If at some point in the future, maybe we could chat about those, like not even a full session, but maybe just like a little PowerPoint or something, just to make sure we're all on the same page. That would be great.
Yeah, I do have a,
Yeah.
actually, that would be easier for me, because I do have some PowerPoint slides that I could modify and put like together a little table, a little discussion. Okay.
Yeah, that would be great.
Do you have a bony unknowns type of thing? Because I think that would be really helpful, because we don't see it that much.
Yeah, I did bone unknowns last year when Heather Smith helped me prepare some of
Oh,
those.
that's right. I forgot.
They should be
Never
in
mind.
the-
Don't repeat.
Okay.
They should be there. Yeah. I
They
just
should be-
forgot.
Yeah, no, that's fine. And I know I have lectures, more of the board style lectures on YouTube with going over bone. So what I can do is I can take some of those, that information, and just maybe not expand, but I don't know, homogenize the osteosarcs and do like a mini osteosarc PowerPoint I can send out to you guys or something. Yeah, but yeah, those are on YouTube. Those all of them are on YouTube if you just look in the BST channel. Aneurysmal bone cyst, I have a request for down here. Let me see if I have one. I know we did one in the, yeah, okay, but you weren't here last year. That's right. We did one in the Heather Smith series. Anyway, I can find one. What else? And if you are on Path Presenter, you could always look in the public slide library to see if you see any examples of cases that you are interested in. So for example, I just went in the public slide library and searched for aneurysmal bone cyst and came up with some examples. The thing is with ABC, not with ABC, the thing is with the public slide library, people put these images up here without anyone like vetting them, without control. So sometimes they may be diagnoses that we don't necessarily agree with. So this looks like actually a quite nice example, but if you ever go looking in the public slide library and you see something that you're unsure of, just let us know and we can buzz through it and see if it actually fits for the diagnosis it's stated to be. So, you know, if you're now thinking about a category of giant cell rich lesions of bone, which chondroblastoma is, as well as aneurysmal bone cyst, right? You can see here the giant cells. Generally, the distinguishing feature for me about an ABC is the stroma in the background being extraordinarily more spindled than what you would see in either a chondroblastoma or a giant cell tumor of bone. And so in areas you have, you know, rich with giant cells, but in other areas you have that characteristic more spindled stroma. You certainly can have the giant cells jumping off the cliff right into the cystic spaces. That's very characteristic. You can have a woven bone. So here you see nice bone. In this case, it has osteoblast rimming, so we can regard that as likely reactive or benign bone. But you can see osteoid. You can sometimes see that characteristic so-called blue bone, which we just had in a case, but I don't see any of that here. Where the osteoid that gets deposited actually takes on an extremely like unusual blue. Here's maybe a little bit. Here's some bluish, kind of purplish bone. So yeah, that for me is the difference of an ABC, is that the background cells and the overall architecture. If you get lucky enough to find a little giant cell that's jumping off the cliff, you're very lucky. All right. Oh, there's a few. Beautiful. Boing. Okay. All right. It's 9. Anything else? Can rely, it's correct. Oh, can we rely that the diagnoses on the public library are correct? No. Is that what you're asking?
Yeah.
No,
Yeah.
I've had trouble with that library before. There are correct diagnoses out there, don't get me wrong, but there are also incorrect ones. And so you really have to kind of vet them yourself or with an attending to determine if they're correct.
Yeah.
I would argue though that if they are in the if they're in the high yield section, so I know that I'm just going to share my screen again, sorry, because this is an important point. If you're in the institutional version, we don't have any high yield cases, but if you sign up for the free, the pathpresenter.net, if you sign up for the free version and go to the high yield cases, these I think are trustworthy because these have actually been placed there by, faculty pathologists from, good institutions who have curated these cases. So for example, The GU Pathology Society even endorses the GU ones. Head and Neck Pathology Society endorses the head and neck ones. So like, these are more trustworthy. The high yield cases are more trustworthy than just the public slide library.
Okay.
Yeah. Okay. Anything else?